Welcome to Educate Nurses, your hub for nursing education, career tips, and clinical skills. Let's learn and grow together.
Today, we are going to discuss about pressure ulcers, a clinical guide for nurses and doctors. Comprehensive overview on prevention, staging, and treatment of bed sores or decubitus ulcers.
Overview. Definition. Pressure injuries, also known as decubitus ulcers, are localized injuries to skin and underlying tissue. They result from prolonged pressure, often combined with shear or friction. Key mechanism. Pressure cuts off blood flow, ischemia, starving tissue of oxygen and nutrients, leading to tissue necrosis. Key facts. Occur over bony prominences where padding is minimal. Can develop very quickly in hours, but are largely preventable. Significant healthcare quality indicator in nursing homes and hospitals. Friction versus shear. Friction is surface rubbing. Shear is internal tissue sliding.
Common anatomical locations for bed sores: sacrum, tailbone area, frequent in supine positioning. Ischial tuberosities, sit bones, high risk for wheelchair users. Heels and ankles, highly susceptible due to lack of fat tissue. Hips or trochanter, at risk when lying on the side. Upper body, elbows, shoulder blades or scapula, and occiput, back of the head. Other, ear rims from oxygen tubing and inner knees.
Risk factors, patient characteristics, physical condition, immobility, the primary risk factor. Age, older skin is thinner and less elastic. Sensory impairment, inability to feel pain. Example, spinal cord injury.
Physiological characteristics. Nutrition. Low protein impairs healing. Dehydration. Reduces tissue resilience. Incontinence. Moisture and irritants break down skin. Comorbidities. Diabetes and vascular disease affect blood flow. Cognitive impairment. Prevents self-repositioning. Weight. Underweight, low padding, or obesity, high pressure.
Risk factors, medical and external. Braden scale, a critical tool for risk assessment. Lower scores indicate higher risk. Medical devices, casts, tubes, and splints can cause device-related injuries. Surgical duration. Prolonged anesthesia and immobility increase risk. Moisture. Sweating or wound exudate causes maceration, softening, or breakdown.
Smoking restricts blood flow and significantly slows healing. Fever increases metabolic demand, making tissues vulnerable to ischemia. Edema, swelling makes skin taut and fragile. History, previous ulcers significantly increase the likelihood of recurrence.
Staging, early intervention. Stage 1, non-blanchable erythema. Intact skin with localized redness that does not turn white when pressed. Color changes may be hard to see in dark skin. Area may differ in temperature, warm or cool, or firmness. Action, eliminate pressure immediately.
Stage 2. Partial thickness loss. Loss of skin involving the epidermis and/or dermis. appears as a shallow open ulcer with a red-pink wound bed. Can also present as an intact or ruptured serum-filled blister. No slough or bruising is typically present.
Staging, advanced tissue loss. Stage 3, full thickness skin loss. Damage extends down to the subcutaneous fat layer. Bone, tendon, and muscle are not exposed. May have undermining or tunneling. Often presents as a deep crater.
Stage 4. Deep tissue loss. Full thickness loss with exposed muscle, tendon, ligament, or bone. High risk of osteomyelitis, bone infection. Often includes slough or eschar. Requires complex management, potentially surgery. Special categories and notes. Unstageable. Full thickness tissue loss where depth is obscured by slough, which is yellow to tan, or eschar, which is a dark scab, and cannot be staged until cleaned. Deep tissue, DTPI, intact or non-intact skin with deep red, maroon, or purple discoloration. Indicates damage to underlying soft tissue from pressure or shear. Documentation. No reverse staging. Never relabel a healing stage 4 as a stage 3. Document as healing stage 4. Measure length, width, and depth with.
Prevention. Mobility. Frequent repositioning is the cornerstone of prevention. Turn bedridden patients every 2 hours. Wheelchair users shift weight every 15 minutes. Support surfaces. Use dynamic air mattresses or foam overlays. Avoid donut cushions. Bed angle. Keep head of bed less than 30 degrees to reduce shear forces. Handling. Use draw sheets to lift, not drag, patients.
Prevention, skincare and nutrition, healthy protein-rich food, skin hygiene, daily skin checks focusing on bony areas. Keep skin clean and dry. Use mild cleansers. Apply barrier creams for incontinence protection. Moisturize dry skin. Do not massage bony prominences. Nutritional support. High protein intake for tissue repair. Maintain adequate hydration to support elasticity. Monitor weight and albumin levels.
Diagnosis and assessment. Early warning signs. Localized pain, burning or itching. Persistent redness, stage 1. Changes in tissue consistency, spongy or firm. Clinical assessment. Physical exam, the primary diagnostic tool. Medical history, identifying risk factors such as diabetes or mobility. Labs, blood tests for nutritional status or infection.
Treatment strategies. Immediate care. Relieve pressure, first line of defense. Cleaning. Use saline or water. Pain management. NSAIDs or topical agents. Wound management. Debridement. Removal of necrotic tissue, surgical, enzymatic, or autolytic. Dressings, hydrocolloids, foams, or alginates to maintain moist environment. Advanced care, infection control, topical or systemic antibiotics. Therapies,
negative pressure wound therapy, NPWT, surgery, flap reconstruction for severe stage 4.
Complications and prognosis. Cellulitis, bacterial infection of surrounding skin or tissues. Osteomyelitis, infection penetrating into the bone. Sepsis, life-threatening systemic infection. Cancer, Marjolin ulcer, squamous cell carcinoma, in chronic wounds. Impact, increased hospital stays and costs, and severe pain. Healing time, varies from days to years for stage 4.
If you have any questions or suggestion, please comments. Thank you for your attention. Continuous education is key to prevention.
Please like, subscribe, and share my YouTube channel. Thanks for watching.